Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm talking with Doug, our favorite ICU doc, and Justin, our comic relief. How are you guys doing?
Awesome. Thanks, Dennis.
Well, and you?
I'm always doing good. Now, the reason I really wanted you guys on is because you just got done doing a sepsis CPG for prolonged field care, and I really think we should walk through this and talk about some of the finer points. I guess starting off, why did you want to do a sepsis CPG, specific for the austere environment?
I know this one kind of came from working with Dr. Keenan and Dr. Shackelford on the wound care CPG. And if the protocols within that CPG failed or somebody had progressed into a pretty bad state in terms of their wound, what was going to be the next step? And maybe the worst case scenario is sepsis. So we wanted to try to come up with some sort of solution for that. I think that was the initial premise for developing this.
So, I mean, is this something that's, very likely to happen in the prolonged field care, or, is this just us nerding out?
I don't know. I've seen a couple of septic patients. They were all indigenous personnel. And to be honest, looking back on it, I'm not entirely sure at the time I knew they were septic. But now after having dug into this and looking back on it, yeah, they were pretty sick patients. And I wish I'd had something along these lines that I could use to manage them. That's pretty much just threw antibiotics and antimalarials at them. And it was a little bit haphazard. And I wish I'd had a goal, something that was a little bit more by the book protocol to take care of them better.
Hey, Doug. So when it comes to sepsis, what are the really important points just to kind of frame our talk here?
Well, one overarching point, and to answer that sort of speaks to your question of, why sepsis, why sepsis CPG and prolonged field care, is that even though, we are in a line of work that is very trauma-centric, distributive shock due to sepsis is actually by far and away the most common cause of shock in the world, in all comers. It's far more common to be super sick because you're infected than super unstable because you're wounded by, a ratio of at least like 2/3 to 1/3 or 2/3 to 20%. So, we may not see that much of it because of, again, our line of work, but it's just around the corner. And anybody who's deployed to, West Africa during the Ebola crisis or anywhere in the world now with COVID-19 out there, knows that the far greater risk to life and limb is really infection and not injury. As far as if I were to say, know one thing about sepsis that and know it cold and absolutely never forget it and do it all the time and you'll have the best possible results. It's early recognition and antibiotics. You can forget all the other stuff. You can even, if people are going to strike me down for saying this, forget about resuscitation. But, in all of the studies that have looked at outcomes in sepsis, a failure to provide timely broad spectrum antibiotics is associated with a mortality risk, and no real studies have shown a mortality risk from various resuscitation strategies. That's not to say don't resuscitate, but if you're going to do one thing for your septic patient right away, give them the antibiotics. Don't mess around with the fluids, and then give them the fluids. Mm-hmm. Unless they're super unstable, in which case you may have to give them fluids and antibiotics. But that's what I would say.
Yeah, I think and CPG kind of lays it out. It's just early recognition. I think is probably the key to really treating anything is just recognizing that it's taking place. So other than just looking at somebody and saying, hey, this person is sick, how can I kind of quantify it to lead me towards this person he's not just a pneumonia patient, or they're not just a malaria patient, but they're also a septic patient. Like, how do I differentiate that?
So sepsis is an infection with any type of end organ dysfunction, right? So altered mental status, confused, lethargic, and infected, you're septic. Decreased urine output, you're septic. Nauseous because you're not perfusing your gut, and anorexic and you don't want to eat, you're potentially septic. So mostly we'll see severe infection with altered mental status. That's probably the most common initial presentation of a septic patient.
Okay.
They're confused. They're lethargic. They're not themselves.
Right. So in the CPG, they lay out like the QSOFA and a News 2 score. Other than just, like your kind of clinical, like your gestalt of just looking at somebody and saying, hey, they're not acting right. Is there value in using these QSOFA or these new scores, or should you just go with kind of your gut on what you see?
They can add some data. News 2 is not well known at all. And in fact, if you asked me to define off the cuff the components of the News 2 score, I would say, can I Google that? Because I don't know. QSOFA, I've had problems with, and many of my critical care colleagues have had problems with, that came out, because I think it leaves a lot of sepsis off the table. It's very specific, but it's not very sensitive. It's very specific because one of its factors, right, low blood pressure, we all know to be a late sign of any shock state, right? The body is going to defend its blood pressure pretty much until the very end. And, whether you're teaching people, hypovolemic shock and hemorrhage, or distributive shock and sepsis, or cardiogenic shock, you're always going to tell your class and your students, hey, blood pressure is a late sign. And if you wait until the blood pressure falls, unless the patient comes in hypotensive, but if you wait until the blood pressure falls, you've missed it and you're behind the curve. So, and again, a bunch of my colleagues, and, not a small minority in critical care medicine, still think SIRS criteria has a lot of validity. Number one is because it catches those, at an early stage, blood pressure has no role in it. Febrile, tachycardic, tachypnic, those are easily observed signs at the bedside that should complement your gestalt that, hey, this patient doesn't look right. And as they get worse and they're more tachycardic and more tachypnic, they should look not righter or more not right. White blood count, okay, leave that out. But even, the paper that established SIRS as a criteria for diagnosing sepsis back in 1991 said, hey, if you have 2 or more positive categories and an infected patient, they're septic. That was the initial definition of sepsis. And I think that still has validity, especially in prolonged field care where we just don't have a lot of kit.
Yeah, absolutely.
Yeah, I know when we were developing this, one of the debates that we had back and forth was, I don't have a lot of clinical discretion in terms of septic patients. I just don't have it because I don't have the experience as a medic. So we were looking for something that was very quantifiable that could give us I guess the best whole patient outlook as to how they were presenting. And so that's why the SIRS is in there, QSOFA, and then the News 2 found its way in there very much towards the end. But without clinical discretion, there needed to be something, I guess, quantifiable, whereas I could look at a patient as a medic who doesn't see this every day and not immediately identify them as being sick, but have some vital signs that I could take a look at and say, okay, well, maybe this guy is in trouble.
Yeah. Greg, Colonel Greg Risk, good friend of mine, who's I've been involved with since early on in my prolonged field care career, said, somebody, on a drop zone after finishing, kind of a hairy jump on a hot day is probably going to be 2 or 3 SIRS criteria positive. And he makes a good point. But the point is, it's context, right? So you have this patient that you're concerned something is wrong with. Well, then what are you concerned about? Are they bleeding out, or are they infected? Or, much less commonly, there's something wrong with their heart. And I think we can probably leave cardiogenic shock off the table for almost all of our prolonged field care discussions. But, let's say, so is he bleeding out? No. Well, then what's wrong with him? Is he dehydrated? Does he have an environmental injury, heat injury? Yes or no? Well, then is he infected? And if you suspect that he or she is infected, and then you apply the SIRS criteria, which is the way it was meant to be done, not just, walking down the street or, Holland drop zone, then it's pretty helpful. And, if a medic called me on a telemed line and said, "Hey doc, I'm in the continent of Africa, and we're in a falciparum resistant endemic malaria area, and I have a patient who, looks really sick and is 3 SIRS criteria positive," I'll be like, "Ooh, that gets my attention."
That's interesting, Doug. That's good stuff, man, for the SIRS criteria, because I didn't know which one, when we were writing this, which one maybe had more emphasis or was something you should look at closer versus the other one.
So other than, assessments, or I guess as part of your assessments, they label monitoring lactate as one of the tools to use. Recently they're talking about using cap refill is as good as a lactate, but cap refill wasn't on, at least in that section of the CPG. Can you kind of walk us through one, why is monitoring lactate important or not important, and is this cap refill, is this something that we really should be doing?
Lactate monitoring is lactate in the blood is generally thought to be a sign of anaerobic metabolism, right? And so that means that not enough oxygen is getting to tissues that require oxygen, and so they're having to provide their own fuel with anaerobic metabolism rather than the Krebs cycle, oxygenated phosphorylation of ATP. And so regardless of whatever reason you're in shock, if you're in shock enough and long enough, your lactic acid can be elevated. And sepsis is no different from hypovolemic / hemorrhagic or any other shock state. Mm-hmm. But, applied to sepsis, let's say, you do have an elevated lactate, and it is being, touted as a performance measure in clinical medicine as well. It's just bloody hard to get a lactate monitor in the field, right?
Right.
Then it's just more data to add to the recipe. It's another ingredient to add to the recipe of the dish of sepsis that you're trying to cook. Mm-hmm. Sepsis management that you're trying to cook, right? If you try to cook any dish with, one ingredient, it's going to taste like that ingredient. If you try to cook it with a bunch of ingredients, you're going to get something that tastes better. So if you try to assess a septic patient, with the SIRS criteria, with QSOFA, with the news criteria, with your clinical judgment, with signs of end organ perfusion like mental status and urine output and a lactate, well, then if all of those needles are moving in the same direction, you can feel either worse that your patient's getting worse or better that your patient, is responding to what you're doing.
Right.
I once heard a talk given by a fellow at University of Michigan, it's called Markers of Resuscitation. And the second slide in big, bold yellow letters on a black background said there are no markers of resuscitation. And I think that's the best point. That's the best way I've ever seen it phrased. There are no single markers of resuscitation. There's a composite picture. And the more ingredients you can add to that composite that move in the right direction, the better you can feel, or worse if they're getting worse.
Right.
Yeah, that's really interesting. And I will say that when Dr. Keenan and I started this thing, we started off with very much a whole patient approach, and we tried to look at it from both my perspective as well as the either receiving doctor or the telemed doctor in terms of what information was important. Because to be honest, lactate, what does that mean to me? I don't know. I guess it should be under 2, I guess. But I don't really know what that means to me. But I bet it means a lot to a telemed doctor, or it means something more to me. And so we really did try to take it from this whole patient approach, try to gather as much information as we can, and understand that telemedicine is probably going to be something that needs to happen very, very quickly. And as much information as we can convey to that doctor on the other end, it'll probably only help the patient more. And I think lactate was an important component that everybody decided on.
Yeah. Because I mean, I think at least from talking to people, lactate like last year was like the new hotness, and now it's kind of fallen out of favor, and now it's cap refill. I definitely agree with you, Doug, that there's never one sign or one monitor or one number that you really want to guide everything off of. It's just that composite picture, looking at the entire patient and see if everything's pointing in the same direction. That probably is the problem. But if you are just tailoring it off of one, you could be going in the opposite direction, or you could be just tricking yourself. The only, I guess, real question I had with the lactate is, it is known that, with anaerobic metabolism, lactate can go up. But with a lot of other things, can also change your lactate levels, like their patients in pain, their sympathetic response, things like that, medications that take away that sympathetic response. So I guess I'm kind of confused on if I'm using that clearance of that, or the reduction in that number, how well is that going to guide me versus, the urine output or mental status or these other things that aren't necessarily confounded, I guess, as badly. I don't know if that makes sense.
Right. Well, I'll go back to, the whole picture, the whole patient approach, or the recipe, right? Because certain elements of, certain markers of resuscitation, or certain things that we use as ingredients to assess resuscitation or assess the need for resuscitation, because they're really just opposite sides of the same coin, right? If they're getting worse, you need to resuscitate it. If they're getting better, then, your resuscitation's going all right. But certain elements of, resuscitation can be confounded. And lactate is notorious for that, right? If you have an acute liver injury for whatever reason, lactate is cleared through the liver to a large extent and can be built up for that. Epinephrine alone can cause, well-known lactic acidosis. We see it in cardiac surgery patients all the time, because a lot of times they come out of the OR needing some epinephrine support to not only improve their blood pressure, but improve their cardiac output when they come off a bypass. And we get patients, who come out who are not in shock, but their lactate levels are, 7, 8, 9 and rising. That would put most people's, that would get most people's panties in a wad pretty quick if they called up or they had a patient and they're like, oh, I got my fancy, finger stick, portable PFC approved lactate monitor, and my patient looks well, but his lactate's 9, So again, the more data points you have, the more comfortable you can feel in the general trend. And if you have an outlier, then I think you look to explain the outlier. You don't follow the outlier, if that makes sense, right?
Right.
If I've got 10 things telling me that my septic patient is getting better and lactate is rising, then I have to find an explanation for why the lactate's rising that's different from their shock state is worsening, because I've got all these other things that are clearly telling me their shock state's getting better, to include cap refill. And I like cap refill. I think that's a super handy it's not new, but it's a sort of newly rediscovered addition to the armamentarium of assessment.
Just moving on to the next section. So just as part of actually finding not only just early recognition, but actually trying to find where the source of infection is. It goes through, your subjective assessments, patient history, etc., objective assessment, and they mention indwelling catheters being IVIO or urinary catheters. And if you've placed them in a less than sterile environment, that can be your source of infection. My question is, since we know, we're going to be in a less than sterile environment, and usually when we do put these in, we're under the gun, right? Or you could be. Should we, when we get to a place of more safety where you have more time, should we almost prophylactically be exchanging out catheters, just assuming that this is dirty, I'm going to replace it with a more clean catheter?
Yes.
Yeah.
Yeah. The short answer is yes. Probably the long answer is yes, but I'll give you a longer answer anyway. But that, that we do that in the hospital. We have catheters that are put in a code situation or pre-hospital by EMS when they come in. And the first thing is to assess, well, do we still need the catheter? And usually the answer is yes, but you always ask that question first, because the best thing is just, if you don't need it, take it out and don't replace it. But 9 times out of 10, you're going to need it. It was put in for a reason. The patient's still unstable. You're going to need it. And so then, yes, if it was put in dirty environment, then take it out and put it in a more sterile environment.
Right.
I'm curious, sir. How many cases of sepsis have you seen that are potentially a result of, I don't know, some iatrogenic thing like a catheter, a Foley, something along those lines?
Hundreds.
Yeah.
Foley, Foley
Okay.
catheter, sepsis, central line. It's rare to the point of being almost non-existent that you see it from a peripheral IV or an IO. It's not to say it doesn't happen, but the risk is so much lower, which is, one of the reasons that honestly in a field environment, IOs and a good IV are really preferable to central lines, because, they deliver fluid pretty much just as well and meds just as well. And they come without all the risks of central line. But yeah, I don't know, hundreds of cases of urosepsis and ventilator associated pneumonia and central line associated infections.
Yeah, that's good to highlight the importance of us doing this properly when, so many times I think we do catheterization of anything pretty cavalierly sometimes.
Yeah.
Perhaps we shouldn't.
Yeah. We've all seen it where the guy's like, I don't have time to clean it. Or I don't have time to put gloves on or something like that. Like, you definitely have time, because if you don't, that's just going to be more resource intensive, just because you're going to have to replace it. Right.
Yeah. An old, a good friend of mine, he was a sergeant major with a special operations unit, now retired, I think said it best. He said, the best field medicine is clinical medicine applied as closely possible to clinical standards. And we improvise because we have to, not because we can. And I would say that, the reasons for doing any type of catheter or device insertion under unclean circumstances are, either your patient is dying in front of your eyes and you absolutely have to get, some resuscitation fluid or blood going because their blood pressure is like 40/20, or you're being shot at. And if neither of those conditions apply, then, clean the area, put your damn gloves on, and do the best you can with what you have. Now, I will say that device-related infections, take a little bit of time after the device goes in. It's not like, I'm going to put in a central line and 5 hours later they're going to be septic. You've got a little bit of time. So, if that patient's blood pressure really was 80/40 and you really did have to get, 6 units of whole blood in to stabilize them, and then they moved, I would just sign off like, hey, this catheter is put in under unclean circumstances. When they get to their next destination, replace their central line or replace their IV.
Very good. We've suspected it. We believe that we've found whatever source it is, either iatrogenic or the wound or whatever. Now it comes down to this patient is hypotensive and we need to do some kind of fluid resuscitation. Like we were talking about earlier, it's very common where people, at least they're talking about vasopressors early. You had mentioned, I think maybe it's a better way to say it is vasopressors concurrently with fluids, but usually they're only talking about the vasopressors. Why are fluids first and not vasopressors, just to get that part out of the way?
Well, fluids are first instead of vasopressors for a couple different reasons. I mean, number one is it's easy to get an IV in and start fluids than it is to, mix vasopressors or figure out how to dose them, right? I mean, even in the hospital, it takes us a minute or, to get vasopressors going, and we generally have bolus bags of fluid lying all over the place. Secondly, if you look at the physiology of, like I said, all of the shock states that we really treat in prolonged field care, which are either going to be hypovolemic or distributive, fluid is a necessary first step, right? Either the pipes are empty because, you've lost a lot of blood or you're dehydrated. Not only that you've lost a lot of blood, but if it's a bowl, dehydrated attack from diarrheal and vomiting, or the container that holds all the fluid has all of a sudden increased in size by 30%, and the pressure head is down because of that. And so you've got, 8 liters of fluid filling an 8-liter container. Well, now the container is 11 or 12 liters, and they still only got 8 liters in it. You've got to top up that. You've got to top up that bigger vessel. Mm-hmm. So that's why fluids are first line.
Okay. So the way the recommendation goes for fluid resuscitation is up to 30 mLs per kilogram within 3 hours. So, the math I think is fine. But how fast are you pushing this fluid? Because I've definitely heard people talking about, dripping this volume of fluid in over 3 hours. I've also heard people talk about just pressure infusing it in very rapidly. So, I guess how fast are you pushing a bolus of whatever amount of fluid?
Well, so if your patient is in shock and you're trying to have a hemodynamic effect from fluid resuscitation, it should be given as a bolus. Okay. Because it should be given as a bolus. The 30 cc's per kilogram, I will reiterate, is a recommendation for sort of the maximum initial resuscitation. Mm-hmm. It is not a goal. Right. It's not, and we see this in burn, as I tell students and audiences when I talk about burns, is like the reason we have 10 different or however many different formulas for burn fluid resuscitation is that everybody takes the latest formula and over resuscitates with it because they see it as a goal, not as a guideline, right?
Right.
And so 30 cc's per kilogram came out of civilian sepsis guidelines developed by the Surviving Sepsis Committee. They're 30% higher than the recommended initial fluid resuscitation guidelines for any other shock state, to include burn, which is burn and hemorrhagic shock, or 20
hemorrhagic shock,
or 20 cc's per kilogram. And so take them with a grain of salt, and for God's sake, don't use them as a target, just as a recommendation. If you give your patient 2 liters of fluid and they're not doing anything, blood pressure isn't coming up, urine output isn't increasing, mast status isn't increasing, well, then maybe you ought to start a pressor, or at least assess whether they need that third liter with some objective measure, being that a straight leg raise or an ultrasound visualization of the left ventricle or the IVC.
Man, that makes me happy to hear you say that, Doug. So often we treat the patient with some sort of formula, like I have to get this amount of fluid into them. But really, that's not the goal. The goal is 0.3 to 0.5 milliliters per kilogram per hour urine output, not just flooding him with 30 milliliters per kilogram of IV fluids.
Right.
Yeah, 100%. Or, mental status is better. The guy now knows his name, or if the guy or the gal now knows his or her name, knows where they are, is following commands, and maybe maybe they still don't have great urine output. And I know we're gonna talk about kidney stuff, probably in the next podcast, in more detail. But, there are all sorts of reasons that the kidney can be injured in any shock state, and only some of them are going to respond to fluid. Some of them will not.
Yeah, and if you're going to flood the hell out of their system with fluids, you should probably check their lungs, I guess, every once in a while.
Right, 100%. The kidneys are pretty resilient, and you can do with depressed renal renal function for a reasonable amount of time. And so, is it really worth it to put, 6 liters of fluid into somebody to get them to pee? And then, you've got to intubate them because they're in respiratory failure for pulmonary edema, which is introducing a whole new level of complexity of care in a prolonged field care environment and risk. Intubating a patient, it is risky in an OR under controlled settings, and it's, risky to the point of, really need to decide whether you need to do this or avoid this in any other environment.
Right. I think just with anything, it all leans to just pay attention to what you're doing, pay attention to the patient's response to it. Just like with burns, like you said, people believe that because I arrived at this number with a formula, I'm going to trust that versus trust my education, my training, what I've see, I guess, because I can put the blame back on the formula, right? And, if you just pay attention to the patient, I think you would be able to guide this fluid a lot better.
In general, in critically ill and injured patients who are in shock, I see bad outcomes from one of two things: either late recognition and initiation of decisive action, or over adherence to a formula and protocolized medicine without accounting for clinical response and assessment and judgment about the patient.
Mm-hmm.
Both of those two things will far more guarantee you a bad outcome than recognize early and treat the patient.
Right. So I think that's good with the fluids. I guess your fluid of choice, is that the one you have, or do you have an ideal?
The one you have in a prolonged field care environment, if you have a balanced electrolyte solution like Ringer's lactate or Plasma-Lyte, that probably has some slight benefits. But if all you have is normal saline or normal saline, then give them normal saline if they need it.
Okay. Now, mentioned earlier in the CPG, they talk about finding the patient's blood type. Is there colloids? Do you ever use a colloid of any kind in a sepsis patient, especially if you're giving lots of fluid?
Yes, just like in burns, at a certain point, if I'm giving them a ton of fluid, which again we've kind of gotten away from. The days of the double-digit liter fluid resuscitation in sepsis are pretty much over. We're going to give 3, 4, 5. I can't even remember giving 5 liters recently. A bunch of fluid, and then we're going to start them on pressors. Mm-hmm. But in something like Ebola, where you've got high output losses, and you're worried about compartment syndrome, then absolutely I'll switch to a colloid.
Okay.
And that could be FFP, it could be albumin, it could be freeze-dried plasma.
Right. Which kind of leads me to this next question. So, say we're giving fluids, we're giving a good response. Go ahead.
Can I do a caveat or an alibi to that last answer?
Sure.
The one place I would give colloids earlier is if I know my septic patient has known heart failure. Obviously that's probably not going to be anybody in our formations, but I just have had some correspondence with some soft elements overseas treating contractors in their 60s and 70s for COVID, and there's one of them definitely had heart failure, ejection fraction in the 40% range. So you definitely do not want to bomb them with a whole bunch of crystalloid, and I would switch to colloid pretty early with them, and really try to limit the fluid they got and go to pressors early. But that's a
unique.
That's a small subset. Yeah.
Okay. But again, speaking about fluids, so we're giving our patient fluids, and we're giving, good response. Their mentation comes back up. Maybe their urine output picks up a little bit, maybe not exactly where we want it, but it's at least is increasing, right? But we have the 2/3 rule with crystalloids. In an hour, roughly a third of it will be left, right? The other 2/3 will third space or the urine output. Do you just continue?
That's worse than that. Yeah, it can be as low as 10% is left intervascularly at an hour.
Okay.
After a crystalloid fluid bolus.
So that kind of
anyway, most of it's not in the blood vessels having any hemodynamic effect.
Okay. So say we're getting some effect. Okay. Is it okay to just continue fluids at a slower rate, obviously, to try and maintain that? Or should that 30 mLs per kilogram, once you've hit, regardless of how long it takes you, say 12 hours or 18 hours, once you've hit that mark, that's too much fluid because it's third spacing, edema, et cetera. Should you then switch to a pressor, or if it's working, is there any real downside to just continuing?
Yeah, and I'm kind of curious if I'm giving a crystalloid and he or she, the patient is peeing, is that in any way giving me a false positive for resuscitation? Like his urine output is where I want it to be, but it's just because it's the crystalloid, not because it's actually resuscitating him.
No, I think, if you're giving them fluid and they're peeing, you're essentially meeting one of your resuscitation goals. And then you should be asking yourself, do I need to, A, give less resuscitation, or B, give no resuscitation and see how they go?
Okay.
Because this is where people get into trouble. They're like, I'm giving them crystalloid and they're peeing and they don't change anything and they keep getting crystalloid and they keep peeing, but now they're at higher risk of having complications, whether that's, respiratory failure from pulmonary edema or compartment syndrome.
Right.
And at a certain point, too much resuscitation will damage the kidneys as well, right? I mean, if you're third spacing from your renal capillaries, and don't forget the kidneys are an encapsulated organ, right? There's a really thick, tough covering around the kidneys. They can't expand indefinitely. I mean, it's not as bad as the brain and the skull, but they're not infinitely distensible. Where you over resuscitate the kidneys, they third space enough into that minimally distensible capsule, and then you start having compartments and renal compartment syndrome. And then your urine output goes off, and you're like, oh, I'm giving fluids, now the urine output goes up. So what's your natural inclination?
More.
I'm giving fluids, right? I'm going to give them more, which is exactly what they don't need.
Right.
So
it's just like with burns. Yeah, just like with burns. I mean, giving more fluid is way easier than turning fluids down, even though all your markers are saying he's had enough.
Yeah. Yeah, there's something in critical injury and illness psychology that is called creep, right? There's fluid creep, there's analgesia creep, there's sedation creep. And we always give our patients more. And we rarely give them less. And when less is usually what they need or often. So it's just something to be aware of and guard against. So, Justin, in response to your patient, they're peeing, I'm giving them crystalloids, cut the crystalloids in half or be bold and cut them off altogether and see if they keep peeing.
All right. I like it. Do you go down the same road as with burns with resuscitation, even though they need ongoing resuscitation? Are we reducing drip rates by 20%, increasing them by 20%? Is that a fair, quantifiable thing to do?
There's no real hard and fast rule. I say to pick a number, go down by something, right? So go down.
I'll pick a number.
Just go down by something, honestly, and see. And if you go down by something, let's say you're cautious and you pick 20%, right? Let's say you're in 100 an hour and you go down to 80 an hour, and then they're still peeing. Well, then, if you still want to be cautious, go down more, go down to 60. Eventually, if they're responders, you'll probably either be able to come off or give them maintenance. And again, the only reason to give them maintenance is that they can't take maintenance oral fluids, or take them off altogether and let them eat and drink and encourage oral hydration. Or if you're bold, great. Go down by 50% and then go down by 50% again and then turn it off, Okay.
Now, how long do you wait? Do you wait an hour before you remeasure?
I'd do 2 hours. I think the fevers and kidneys, I think, are something I would assess over a couple of hours unless there's something really acute. If you wait an hour for a fever and it jumps from, 100.5 to 105, well, then obviously I'm not going to wait for the second hour.
Right.
But if it's 100.5 for an hour or 7 for an hour and it's 100.5, I'm probably not going to jump on doing anything about it. Mm-hmm. Same thing with urine output. Give the organ a little bit of a chance to adjust. And if it's, in general, I'd say, 2 hours is probably a better time frame.
Okay.
Even if they're anuric, if they're anuric, it goes both ways. If they're not making any urine at all and you've got, a reasonable fluid strategy, give it time to work. And if it's not working after, a decent amount of time, 2 hours, then readdress it. And then, then you've got to ask yourself probably some of the questions we'll get into in the next podcast. Is it not working because my fluid strategy is bad? Not bad, but, my fluid strategy needs revision. Or is it not working because they have some sort of a renal injury that's not going to respond to fluid?
Right. But that's another podcast. So
that's another podcast.
Now our decision to go to vasopressors. So when you're first giving your fluids, right? Maybe you're 1 bolus, 2 bolus, whatever you feel comfortable with. Okay, you've picked a number and you've gone with it. You're not getting any joy out of it. Now you decide to go to a vasopressor. Kind of the druggist choice is, right? How about this? Actually, what tells you with that fluid bolus, I'm not getting what I want out of it. So I'm not really how do you quantify his mental status didn't go up enough, right? It probably would change a little bit, but where do you draw the line of this is enough, this is not enough?
I think any positive change is good. Keep going with your strategy. If you're seeing positive changes, I would say no change. They're still confused. They're still obtunded. They're still not following command.
Okay.
And their systolic blood pressure is still less than 90. I'll use systolic. I use MAP, but that's fine.
Mm-hmm.
But the systolic blood pressure is still less than 90.
Okay. So
can I be a jerk and ask you, after how long and how much fluid, if I've given them a bunch of fluid and X number of hours have passed, when am I going to make the decision to pull the trigger on a vasopressor without improved blood pressure?
I would probably do it, lick my thumb, put it in the air, feel the breeze as I'm giving this answer, a couple liters of fluid over a couple of hours.
Okay.
And this is all predisposed. This is all predicated on, I do not have a super unstable patient who's threatening to die on me, right? A patient, a GCS of 3, blood pressure 50 over 30 or 60 over 40. This is less, sick, but not unstable. Does that make sense?
Yeah.
Right.
Okay.
Right. So there's sick or not sick, there's stable and there's unstable, and then there are trends, better, same, or worse. So sick, unstable patient, you're going to probably hit them with fluid, you're going to hit them with a pressor, and you're going to try to get, a blood pressure that's acceptable, and hopefully the mental status will follow. But at least, you've got a blood pressure that's compatible with life.
Okay. So they're out of it. I've given them a substantial amount of fluid, like a couple of liters, no change. Right. Then maybe I'm going to drop some pressors.
And again, your pressors are really for blood pressure, right? Yeah. Pressors are not for pressors are only for blood pressure and a little bit of cardiac output, which definitely governs blood pressure. You're not giving pressors in a normotensive patient. And by a normotensive patient, I mean a patient with a systolic blood pressure of 90 or above, or a mean arterial pressure of 65 or above. And a lot of times we'll even, cheat on that a little bit or shade that a little bit and be like, wow, let's let them get down to 60 and see if we need to give them pressors. If they keep falling to 60, I'm like, okay, I probably need to turn something on. So but that's an important point, is that you only give pressors for hypotension. It's not for, you don't give them in a normotensive patient to make the urine output get better. You don't give them in a normotensive patient to get the mental status better.
Oh, okay. Okay. Oh,
right.
Yeah, makes sense.
And by normotensive, I mean low normal blood pressure. A mean arterial pressure of 65, which can be, you can have a blood pressure of like 80 over 30 and have a mean arterial pressure of 65. I think, I'm not doing the calculations in real time, but you'd be amazed at how low a systolic blood pressure you can have and still have an adequate mean arterial pressure, which is what the brain is seeing in terms of perfusion pressure, which is kind of what we go by.
Okay. But I mean, by fixing that blood pressure, fixing that number, hopefully you're fixing the perfusion, which then fixes the other problems. Is that correct?
But that number has got to be, the number one has to be hypotensive, and two needs to be pretty bloody hypotensive for you to need pressors, which, you can be. I mean, you can have, systolics in the 70s, systolics in the 80s, in sepsis and septic shock. And you're really in septic shock here. You're not just in sepsis when we're talking about using pressors. And then, you absolutely need to start a pressor.
Right.
And your fluid's either going to bring it up or it's not. Sorry, Justin, go ahead.
No, I'm sorry. One of the things I'm curious about is what can I expect to see in a patient if I do push epi? Because I know epi versus norepi is going to have some respiratory effects, obviously some cardiac effects, and they're going to be a little bit different. But if I'm pushing epi instead of norepi, because that's what I have, what do I expect to see happen in my patient if I get a good response? Let's just call it a good response. Like, what are the side effects? And
probably not a lot different. Honestly, the negative side effects of epi that you might see are some tachycardic arrhythmias. So, SVT, supraventricular tachycardia, maybe some PVCs. So it tends to be associated with a little bit more rhythm instability than norepinephrine, but not nearly as much as dobutamine or even dopamine in high doses. So but you may see that. And then the second thing is if like I said, you do have your fancy TFC seal of approval field lactometer, you can actually see lactic acid rise in response to epinephrine. But again, you're probably not going to have that.
Yeah,
so tachyarrhythmias would be the number one.
Is something to be aware of. If we're pushing epi as our vasopressor, that it's going to potentially affect your lactate levels.
Yeah. So, but again, you have to balance the side effects versus, the side effects of having a systolic blood pressure of 50 are, pretty severe. And so a lower dose given as a drip rather than a push, all of those are associated with a little bit less rhythm instability. Giving calcium in addition to epi can calm down the risk of instability. Sometimes even giving bicarb as well, but calcium for sure. And in most of our unstable cardiac patients, we're giving them pressor and calcium.
Okay. Is that just because of you're kind of replenishing that calcium because it's been like hypoperfused? The heart has been hypoperfused, or is there another reason?
Partially because they've been on cardiac bypass, but also it reduces it stabilizes the electrical conduction system of the heart, and can help get you out of an unstable rhythm and into a more stable rhythm. And so if you've got, and you can be in an unstable rhythm for all sorts of reasons, from inflammation and sepsis and toxins and hypoperfusion, the list is long. So if you give them epinephrine and they go into a less stable rhythm or more tachycardia, sometimes you can mitigate that with some calcium.
Okay. Would you give that prophylactically?
No, I would give the epinephrine and see if I need it.
Okay. All right, good. So really the other main pillar that we haven't gone over yet, we've gone over early recognition, identify where the source is through our assessments. We've gone over fluid resuscitation. So we've prevented them, or hopefully prevented them from dying. Now we have to actually get control of the source itself. That can be through antibiotics, that can be through wound management, or just removing that offending source. I guess quick on antibiotics, or antiparasitics, obviously it can be more than just a bacterial infection. I've heard guys talking about ertapenem, and that it's really falling out of the favor because of, increasing infections downstream. Okay, roll 4 or roll 3, roll 4, etc. So they're kind of leery, I guess, of using ertapenem versus Ancef or something like that. As an ICU doc, what do you think about that, Doc? Should I just go with the big gun right away and try and get control, or should I be more selective?
I'd be curious to see what kind of guys are concerned about this. I have my, yeah.
I guess, what do you mean, guys? As far as unit, or?
No. It's like, who's voicing these concerns? Because we've been kind of in prolonged field care saying ertapenem is pretty much our drug of choice for critically ill, unstable patients, because it's easy to dose, it covers a broad variety of things, and has pretty minimal side effects.
Yeah.
It's also easy to administer for a medic in the field. It's not a hard drug to administer, and if you screw it up, the side effects are, like you said, they're pretty minimal.
Mm-hmm.
Right. I sort of fall on the side of, one of my trauma surgeon friends who said, that there are far greater insults to the cause of antibiotic resistance than giving a few doses of ertapenem in an urgent, prolonged field care austere situation.
Right.
Nice.
It's only going to be a problem if he lives long enough. So give him the antibiotic, and then we can kind of suss things out later on, I think.
Well, it's actually only going to be a problem if we give it to so many people that the bacteria then is able to select for resistance to that antibiotic as a survival tool. And that's not going to happen with, double digit, even triple digit. We're seeing mutations in the coronavirus because hundreds of or tens of millions of people have the disease.
Mm-hmm.
You're going to see antibiotic resistance minimum in the tens to hundreds of thousands of people who get an antibiotic. So, like I said, like she said, far greater things have been done, in the cause of antibiotic resistance than giving a few doses of ertapenem in an austere emergency situation. So I wouldn't be too worried about it.
Okay.
Hey, just out of curiosity, sir, what do you guys give in a hospital? Like if you had, which you do have, all the antibiotics in the world, what do you guys typically go to treat sepsis?
Sure, that's a great question. Our go-to empiric coverage in a hospital is going to be an antibiotic, number one, that cover resistant organisms, right? Because we're in a hospital and that definitely breeds resistance. We give so many antibiotics. And the bacteria are in a relatively confined environment, right? Our hospital or somebody else's hospital. That there's heavy pressure for resistance. So MRSA and Pseudomonas are the big two. And so we will give some sort of a gram-positive agent against MRSA, the most common of which is vancomycin. And then we'll do either one or two gram-negative agents against Pseudomonas, which isn't against Pseudomonas. And there's evidence for both. We tend in our hospital to give only one and then see how they do. And if they get sicker, add a second. And so that could be Zosyn, which is piperacillin tazobactam. That's a anti-pseudomonal penicillin. It could be cefepime, which is a fourth generation fluoroquinolone. Those are probably the big two. Or it could be meropenem or imipenem. The important thing about ertapenem is it does not cover Pseudomonas. So even though it has penem at the end, just like the carbapenem, it's the one thing it doesn't cover is Pseudomonas, which is why you won't see us give it in the hospital very much.
So outside of just giving antibiotics, especially if you're talking about war wounds or breaks in the skin, you're going to have to do some kind of wound management. So that's another reason why I asked you to come on, Justin, because you helped with the wound management CPG. I guess how are you approaching, wound management? Because generally, we in the field, we work real quick to cover up the injury, and we may not be so quick to do a good irrigation or even a real sloppy debridement. So I guess when are you going back and actually focusing on wound management?
Yeah, when I was looking up research about this and talking to people about sepsis and its prevention, which is what wound management is for me, is it's not necessarily managing the wound like we talked about with urine output. There's a goal to it, and the goal is always infection prevention, I think, for me anyways. But one of the things that most people said to me was good debridement. Irrigation is extremely important. It's a pretty rudimentary skill. I don't want to say that as if it's a cavalier task. Like, you should still probably be judicious about it. But ineffective debridement is one of the biggest causes of sepsis for war wounds. I don't know, Doug, do you got any input on that? That's pretty much what I've seen or read.
No, I agree 100%. If there's devitalized tissue there, you can irrigate it all day long, but it's still going to be a source of infection for when the water goes away. And probably the most important thing, which I'm sure you wrote about in the CPG, is, look at the wounds every day. Don't let them hide under a bandage. And at a minimum every day, and ideally, twice a day. Early on is probably when the biggest risk of tissue devitalization is going to occur, because the area of hypoxia that causes the devitalized tissue is sort of evolving in the first few days. And so that's when you're probably going to see the highest risk of non-viable tissue and infection risk if it's not debrided.
Yeah, and one of the other things to think about is that biofilm that's going to start covering that wound after a day or so. You have to scrape all that off. Okay, so not only just the devitalized tissue, but any kind of the biofilm that's going to cover that. It can start covering like urinary catheters. It can start covering ET tubes, crikes, things like that. But after a day or so, this film, that bacteria is going to create this film. And if you don't get it off, your antibiotics are not going to penetrate through that. That's the bacteria is creating that to protect itself. So you have to actually debride that off in order for your antibiotics to actually be effective at all. Do you guys have anything you'd like to add that we didn't cover about sepsis or the CPG?
I guess the only thing I would add is in terms of source identification, most of the literature that I read, regardless of what is causing it, whether it's a parasite, a bacteria, a fungus, you're always going to give antibiotics. And if Dr. Powell has some other input on that, I'd love to hear it. But that's pretty much what I read. You're always going to give antibiotics. And then the next step, if he's not getting better, he or she is not getting better, you have to ask yourself, well, if this could be on my differential or on my index of suspicion, i.e. malaria, for example, and I treat him for malaria and I'm wrong, am I hurting the patient? In an austere environment, that's a pretty important question. So if I treat him for malaria and that person doesn't have malaria, am I making them worse? In the case of malaria, probably not. So that's just one of those questions you have to ask yourself in terms of your differential. In terms of a fungal infection, that is absolutely a telemed question, because yes, you could be hurting them substantially. I don't know. Do you have any insight on that, Dr. Powell?
Yeah, I mean, it's rare that you have a septic patient. In fact, I'd say it's probably rare to the point of you'll never see it, where you have a septic patient and an infected patient and you don't start with antibiotics. So, even in the hospital where, we immediately have a GI infection, which can be fungal, we're always, the first 24 hours, really the first 48 to 72 hours, they're always going to be on broad spectrum antibiotics. So for the purposes of this discussion, you should have them on antibiotics, but you should also, know what your endemic risk is. If you're in a malaria area, like you said, it's probably better, and they're super sick. It's probably better to assume that they have malaria and add an antimalarial, and then take one or the other away when you have your diagnosis, right? You do your malaria test, and if it's positive, you can probably pull away the antibiotics. If it's negative, you probably need to keep the antibiotics and pull away the antimalarial. So that's the one obvious case I can think of in our operating environment.
All right, outstanding. Is there any other tidbits you have, Doug?
No, gosh, thanks for the chance to comment, and Justin, solid work on the CPG. Those are never easy. It's a lot of cat herding, and I think you did an exemplary job. So it's great to see it out in the community for reference.
Hey, thank you very much, sir. I appreciate that a lot.
Okay.
I just want to say what a privilege it was to be the team lead on another CPG, to be asked to do that. It was a real honor. And it was especially an honor to get to be mentored and work on a project like this with Dr. Keenan, Dr. Shackelford, Dr. Mays. These were the people I had the most contact with, and most definitely Mike Certoni, who is a fellow peer of mine, but most definitely a mentor, and somebody that I would very much like to take the opportunity to mention and thank, and that's my wife, Andrea, who I don't think I really truly realized was a mentor until I looked back on the development of this CPG. She's a nurse in the 12th busiest emergency department in the country. She works very hard. She's a very compassionate nurse, and I learned a lot about sepsis from her, and it was kind of unbeknownst to me because it was very much conversations, because we're medical personnel, so it doesn't gross us out at the dinner table, but there were very much conversations around the dinner table and in the evening about the patients that she treated. And so I learned a whole lot to her, and very much of that wove its way into almost every element of the CPG. A lot of the information was something that I had to chase down, but I didn't realize what a mentor my wife was to me. So thank you very much, honey. I love you.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.